Hello everybody, good evening and welcome to BioMonde Live. Thank you ever so much for joining us on our first live webinar of 2023. Now, as you can see, I'm not alone this evening. I am joined by our expert guest, Carole Young, who is going to be presenting for you. But before we formally begin the webinar, I'll just run through a few quick points with you all just to make sure that the evening runs as smoothly as possible. Now, as I've said, we're joined by our expert guest, Carole, and Carole is presenting on the wound healing process and wound assessment for you this evening. Now, tonight's session is going to last around about an hour, but timings may vary ever so slightly, so do just bear with us and sit tight and enjoy the evening. And we will be setting aside some time for some Q&A this evening. So if you do have any questions that you've got for Carole, do just pop those into the Q&A button and we'll be answering them live at the end for you. Now, if you're not familiar with Zoom or if you haven't joined us on a live webinar before, you can find both the chat and the Q&A buttons just at the bottom of your screens. And I can see lots and lots of you are saying hello and networking, which is amazing. And thank you once again for joining us. So, as I've said, Carole is your presenter this evening, and Carole is an independent tissue viability consultant and an associate lecturer at Anglia Ruskin University. Now, what's Carole going to be presenting for you tonight? Well, Carole's going to be looking at the etiology of the wound healing process and what can prevent healing at each stage. She's also going to be looking at wound assessment with both holistic patient factors and local factors that can impact wound healing, as well as some strategies in wound management at each stage of the healing process, and including when larval therapy may be appropriate for you as well. So that's it from me for now, everyone, but I will pass you over to Carole, who will be presenting. So Carole, whenever you're comfortable, if you'd like to share your screen, and then you can begin your presentation. And thank you once again for joining us. I really can't wait for this presentation. It's going to be amazing.
Thank you ever so much.
Thank you.
Thank you, BioMonde, for inviting me to come and present today. It's really exciting and great to be kicking off the BioMonde education sessions for 2023. So I'm really looking forward to it today. So, as I've been introduced already, I'm Carole Young. I'm an independent tissue viability nurse consultant. I also educate through being an associate lecturer at Anglia Ruskin University, and I'm also a nurse advocate, which means I give mentoring and coaching to other specialist nurses around the country. The session this evening is taking us back to those fundamentals of wound healing and looking at the physiology, the wound healing process. And then we're going to be looking at wound assessment as well. So let's start off with some objectives. So hopefully by the end of tonight's session, you'll hopefully have gained an understanding of the normal wound healing process and gain an insight into complications that occur during the wound healing. And we'll gain some understanding of the holistic factors and the local factors that affect wound healing in patients. And that will hopefully give you the knowledge and skills in order to go away and assess a variety of wounds. I'm going to introduce you to where larval therapy could fit in with the different stages of wound healing. So before we go about assessing and managing wounds, there are some essential things that we need to have. And these are a knowledge of wound healing and physiology and the factors influencing wound healing, which you'll hopefully get from today. And this helps us to understand what's happening beneath the surface and why. We need to understand the factors that are impacting healing so that we can understand when things aren't progressing as we would expect them to. We need to ensure that we have a holistic patient assessment so that we can relate our physiology to our individual patients, so that we're always looking at for the whole of the patient, not the whole in the patient. We also need to make sure that we've got the appropriate equipment and wound management products to promote our healing. So before we get into the wound healing process itself, we're going to look at just a bit of a reminder about the area of the body that we're talking about. We're going to look at the skin and the underlying tissues. Remembering the skin anatomy helps us to understand what is impacted when a wound occurs and why, as we age, our skin responds differently. The skin is our largest, but often our most forgotten and neglected organ in our body. When we are sick or have had a trauma, our body protects our major organs, such as our lungs, our heart, our liver, and our skin gets forgotten as the blood supply is moved to the essential organs first. This leaves our skin really vulnerable and susceptible to failure or breakdown. Our skin is made up of two primary layers, the epidermis and the dermis. Both of these contain the capillaries, the sweat glands, the nerve endings and the hair follicles, all of which have really important roles in protecting us. And that is our skin's primary role, is protecting us. It protects us against pathogens and UV radiation. The skin manages our temperature. It thermoregulates by using sweat glands to cool us down and hair follicles to trap air to keep us warm. It also is really important for sensation. Our nerve endings in our skin allow us to sense if we're touching something hot or cold, or if we're potentially harming ourselves by touching something sharp. Skin is also the enabler for metabolism of vitamin D, which is absolutely essential for our bone and teeth formation. The skin is also really important for communication. Our facial expressions, when we speak, if we frown or wince in pain, our skin moves on our face to tell others how we're feeling. And that's really important when we're looking after patients, when we're looking at those non-verbal signs of communication, particularly with wound care, that we're not actually hurting somebody while we're doing things. Beneath the dermis is the fatty layer, otherwise known as the adipose layer. And this is our cushioning layer. It cushions and protects all our underlying structures, and such as our tendons and muscles, our bones and organs. But it breaks down rapidly if it's exposed in a wound, which can lead to an even deeper tissue loss and risks of deep infection. So when we're born, our skin is really already very immature, with thin epithelial scales and a very limited protective barrier. A neonate skin can't maintain its hydration very well, so it rapidly becomes dehydrated and loses elasticity and ability to repair. As we grow through childhood, adolescence and adulthood, our skin matures with a full quota of skin cells and gives us our maximum protection and a barrier against pathogens. And it gives us our optimum sebum or oil production, so we've got good vascularity and elasticity in our skin. But we are still susceptible to drying, sunburn and injury. But as we're more mature and older, we're aware and able to care for our skin. Then as we age, our skin reverts back to a similar state. So almost like when we were neonates, the epidermis becomes thinner again and our protective barrier is reduced. An average 80-year-old's epidermis is 50% thinner than that of a young person. Our skin becomes dehydrated quicker. Between 70% and 90% of people who are over 65 and in hospital or care environments have clinically dry skin. That's skin that needs treating because it's so dry. We lose our ability to maintain a protective barrier, and healing is slower. So we become much more vulnerable to trauma such as skin tears and bruising. There's a higher risk of pressure damage and moisture damage. Additionally, there's also higher risk of vascular compromise as we age, particularly venous hypertension, leading to leg ulcers and poor healing. So it's essential that we look after our skin throughout our lives. Everybody should be moisturizing. So let's start to think about what happens when our skin breaks down and we might develop a wound. Let's start with that question. What is a wound? Is there a definition? And what do we mean by healing? So a wound could be described as any breakdown in the continuity of the skin. This could be a surgical wound as an incision or a laceration. It could be a trauma or a leg ulcer or a pressure ulcer, for example. But how do we differentiate these different types of wounds? And how do they all heal? Let's go through this in a bit more detail. So we can classify wounds as chronic or acute. Chronic usually means a long duration and possible reoccurrence and probably slower healing. For example, leg ulcers, pressure ulcers, some dermatology conditions, or malignant wounds. Whereas our acute wounds are much newer, a short duration, such as something like a surgical wound or a trauma such as burns, cuts or grazes are usually our acute wounds. Depending on the type of wound, we might describe the way they heal differently as well. You might have heard of terms like primary closure or secondary healing before, and we're going to just have a recap on those and what those mean. So primary closure refers to a wound where the edges have been brought together and effectively closed the wound. This allows the wound healing process to progress much more rapidly, and there'll be little tissue loss or disruption. There should be minimal risk of complications or delayed healing, minimal scarring. Examples of this are surgical wounds or skin tears where the edges can come together, and they may have been closed with sutures, staples, glue or adhesive strips. A secondary healing occurs when the wound edges of the edges of the wound can't be brought together. So the wound needs to heal from the bottom up, filling with granulation tissue over time. These wounds are open for longer, so they're much more at risk of infection or delayed healing. Examples might include our leg ulcers, pressure ulcers, burns, or any trauma where there's a significant tissue loss and the wound's open. And then additionally, we have delayed primary or tertiary healing. Now this is generally a primary closure wound that's not been able to close immediately. So it might be that a surgical wound where there's been significant edema during a procedure and the edges can't come together and they'll need to be closed at a later stage. Or it might be that the wound has been contaminated or infected and that wound needs to drain or receive some topical treatment before it can be closed. These wounds tend to result in a wider scar and they might require grafting and sometimes multiple surgeries as well. Regardless of whichever type of healing, the process that is going on underneath with the cells is exactly the same. And we're going to go through that next. So as I said, whatever the type of wound healing, the physiology or the healing process within the cells is the same. The time frame might be influenced by whether the wound edges are brought together by primary closure or whether the wound is open and healing by secondary intention. Wound healing process follows these stages: hemostasis, inflammation, proliferation, that includes granulation and epithelialization, and maturation. We're going to go through each of those stages in turn. As we go through each of these stages, we're going to consider what we should see in normal healing conditions, what might go wrong at each stage, and we'll consider whether larval therapy will be helpful at each stage as well, and also when it's contraindicated. So let's start at the beginning. The first thing that happens when we get a wound is that we bleed. Bleeding flushes out the wound and it's our body's emergency response to injury. It removes any contaminants, but it also triggers the body's response. So blood vessels around the area start to contract. We get vasoconstriction, that limits the bleeding and starts to reduce the blood flow so that we don't bleed to death. Then platelets and fibrin form a clot, which acts like a plug and fills the wound for now as a temporary cover. And that prevents any further contamination and also puts some pressure on those fragile vessels to stop the bleeding. So what will we see in practice at this stage? Well, in normal circumstances, we should see an initial blood loss, followed by bleeding slowing and stopping, and a clot forming in the wound. But sometimes things can go wrong at this phase. It might be that the bleeding doesn't slow or stop. Have a think about any patients that you might have that may have a medical history such as haemophilia or medications such as anticoagulants, blood thinners. Those things stop clotting happening, so they could cause a problem at this stage. The other problem that might occur is that a tense hematoma might form under the skin without any breakages in the skin, and that will increase a risk of further breakdown later and possibly quite a significant tissue loss. So let's think, can we use larvae at this stage? What do you think? It's really important that we remember that larvae is contraindicated in wounds that are close to exposed vessels or organs or very close to them. It's also contraindicated in patients who are prone to bleeding. So think about those patients on that medication or with a medical history. However, it might be useful in helping with breaking down hematomas if they're not resolving or lifting naturally with conventional dressings. Larvae release enzymes that can help to break down devitalized tissue. However, I would say be really cautious at this phase of wound healing, because the wound and the underlying vessels are incredibly vulnerable, and there's a big risk of larvae disturbing a clot and bleeding recommencing. Our next phase is the inflammatory phase. Once a clot has formed, it moves on to this phase. We should start to see that clot dry a little bit to form a scab. Damaged cells beneath release histamine, which causes the local blood vessels to dilate. And we need this to happen because we need all the cells and growth factors and proteins to come into the area to help with wound healing. The tissue surrounding the wound will become quite inflamed and with a rise in temperature and redness because of these dilated blood vessels. But we start to see things coming into the area such as neutrophils to fight off any infection. Chemokines are released to attract white blood cells, which trigger the next bit, phagocytosis. Now, phagocytosis is the destruction of pathogens by neutrophils and macrophages. They will migrate into the area and ingest the debris. And this is really important. We need this to happen because we need room for the next phase to happen. We need room for granulation tissue to occur, and it can't happen if the wound is full of debris or dead cells. The next bit will be the angiogenesis. That will be starting underneath as the debris is lifting. And this is the formation of new capillary loops. And that gives quite a red nodular appearance, but it won't happen until the macrophages have finished their job. And we move slowly into the proliferative phase. But what will we see in the inflammatory phase of healing in practice? In normal healing wounds, we should see signs of inflammation. So it'll be red and swollen. We should see serous or hemiserous exudate that's quite thin in consistency. There might be visible slough, which is white or yellow tissue as the cell debris reaches the surface. And that might start to lift and become loose. Our patient might be experiencing pain as the nerve endings are exposed and agitated by this inflamed tissue. But the inflammatory phase is probably the phase when most things are likely to go wrong in healing. It's the most likely time that we'll see infection. With all the devitalized cells comes the risk of infection. Bacteria thrive in moist environments with decaying tissue. Wounds can get stuck in the inflammatory phase as well, particularly if somebody's got a medical condition or medication that impacts on inflammation. So again, think about your patient holistically. Are they taking long-term anti-inflammatories or steroids? Do they have a condition such as diabetes or a rheumatoid inflammatory condition that might be impacting on this phase? And wound edges can be particularly prone to maceration at this point if exudate becomes too high, further risking a bigger breakdown and the wound becoming bigger. So, could we use larvae at this stage, do you think? I think yes, we can. Larvae excreting those enzymes which break down non-viable and necrotic sloughy tissue and bacteria, particularly biofilms. So they can be really helpful in this destructive stage of this phase and clean up the wound ready for the next proliferative phase. So then we come to this proliferative phase, and this is really where all the action is. This is the rebuilding and repairing, the tissues filling in space left by any tissue loss in the inflammatory phase. We start to see angiogenesis really in full swing, producing new capillary loops in the wound there to deliver cells that are needed for new cells to form. We see fibroblasts multiplying and forming a scaffold, a bit like a haphazard spider's web. and then collagen fibers supporting the fragile capillary loops. This is known as the extracellular matrix, and it supports the fragile capillary loops and the new granulation tissue as it starts to fill in this space, a bit like bricks and mortar filling in a hole in a wall. We also see other cells around, cells called myofibroblasts. And these are muscle cells, and they will be starting to contract the wound, pulling the cells together and making the wound smaller. As that wound becomes smaller, it becomes easier for the space to fill with new granulation tissue. And as that granulation tissue fills the space, then the epithelial, the skin cells, can start to migrate across the wound, but they can't just come across if there's nothing for them to cling to. They can't suspend in space. So what do we see in this phase of healing? We should see a normal primary intention closed wound. Normal suture line with some very slight hemoserous exudate, a very small amount, but it should be pretty dry with a visible line of epithelial tissue across the scar line. A secondary healing wound will be bright red with a nodular, bumpy appearance as those new capillary loops develop, and you might see some pale pink epithelial cells at the very edges of the wound. If you've got a wound with a very large surface area, you might also see some of those epithelial cells in the middle of the wound as little dots, so they tend to migrate from where the hair follicles were. But things can go wrong in this phase as well. Infection can set in at the proliferative phase as well. And if it does, what we see is that granulation tissue not looking healthy and bubbly and red anymore. We see it still red, but it might be fragile. It might be smooth and shiny looking rather than nodular. There might be an increase in exudate and more maceration around the wound. That really fragile granulation tissue will bleed really easily if it's touched. It's known as friable granulation. So should we use larvae at this stage, do you think? Larvae are not likely to help this phase of wound healing, because if everything's going well and we've got good granulation tissue, there will be minimal non-viable tissue present, and the new blood capillaries are going to be quite fragile. If all goes well, we should move into the next phase, which is maturation and remodeling phase. And this is the longest phase of wound healing. It can take up to 2 years for scars to settle down and get as strong as they're going to be. The scab will lift and we get a decrease in vascularity. So as that scab lifts, all that new epithelial tissue is exposed and you can see it right across the wound. Those dilated blood vessels that were bringing everything into the area before are going to return to normal size. The myofibroblasts that were helping with contracting the wound in will finish that contraction to ensure that the wound edges stay together. The fibroblasts and the collagen matrix that were quite haphazard before become more organized. They start to flatten down. So the scar starts quite peaked and ragged and over time flattens down. We start to see nerve endings coming back to life, and what you might hear is patients complaining of pins and needles or weird sensations in their scar tissue as those nerve endings come back to life. Interestingly, scar tissue only ever regains about 80% of its original strength compared to non-wounded skin. So there's always going to be a risk of further breakdown. So if we think about patients who maybe experience multiple pressure ulcers or recurring leg ulcers, that scar tissue is weak and will become weaker if we get recurring wounds over the same area. So what will we see in practice at this stage? We should see a normal healing wound on the surface. The hair follicles may be absent though, they don't always return. And pigment doesn't always return either. So you might find that scar tissue is very much paler than the surrounding skin, or in dark skin tones, it can actually look darker, sort of a more purpley colour, or be completely absent of pigment and be very pale. Patient might be left with bald patches where the hair follicles do not recover. So think about your patient's quality of life and their body image at this stage. You know, it could be quite distressing if patients had a wound on their head and their hair doesn't grow back, or on their face if they're male and they had a beard and that facial hair doesn't come back. Scar tissue itself can come with a lot of taboos or status depending on your culture. Scars can be still very vulnerable though, and things can still go wrong at this stage. They can still develop infection, especially in areas where there's heat and moisture. So things like skin folds, or areas under constant movement, like the sternum as we breathe in and out if you've had chest surgery, or joints over the knee, the elbow, the hip. These can be areas where the scar tissue doesn't gain its strength, so it can break down easily. Some people might have connective tissue conditions, which lead to keloid or hypertrophic scarring. Again, this is because that collagen matrix underneath isn't strong enough to keep the tensile strength, and the epithelium doesn't remain strong. So it looks almost stretched, almost like a stretch mark sometimes. The wound can also break down even at this stage for all sorts of reasons. It might be mechanical or traumatic, something like self-harm or recurrence or cause. So if it's a pressure ulcer and we haven't effectively relieved pressure, they may get another pressure ulcer in the same area. There may also be an underlying foreign body that works its way to the surface, maybe a little piece of suture material of a surgical wound that hasn't been removed completely, will work its way to the surface, and the body will naturally try and get rid of foreign bodies, so it will open that scar up again. So do we think that larvae should be used in this phase of wound healing? Well, probably not, because hopefully if everything is going well, we should have a nicely healed wound. But that new scar tissue could be quite fragile, so probably not going to be needing our larvae just at this phase. So healing is complicated. We have so much more to learn about the process. Science is progressing all of the time. We are constantly learning new things, particularly about cells and microbiology. But although wounds take varied periods of time to heal, they will always use that same process, whether it's a primary healed wound or a secondary healed wound or a tertiary healing wound. They're going to follow that process of hemostasis, inflammation, proliferation, and maturation. The time frame may be different. So remember, when we come to looking at wound assessment, think about that physiology and relate it to your patient's underlying general condition and what is going on at different times of healing as we go through this process. Which leads us very nicely onto our next section, which is looking at the patient and wound assessment. Let's think for a moment about why do we assess and how do we assess? Why is it important? Assessment enables us to have effective and appropriate care to be planned. It also helps us to evaluate and document wound care progression. And most importantly, it helps us to see if there's any deterioration, if a wound is getting bigger or something is changing. Our assessment can really help to improve the morale of patients and carers by showing their progress. And patients can be really involved in this, and they might keep their own records. They like to keep their own photographs these days to see how wounds are progressing through. Very important when we're thinking about our wound assessment is that we are making sure that we are doing it at the right time and the right place. What is happening in the patient's environment and with the patient at that time? Are they clinically stable? Is the environment calm? If they're in hospital, we don't want to be taking dressings down if there are things going on like cleaning or medication rounds or lunchtime. In the patient's own home, we want to think about other things, maybe pets in the room or visitors coming. We need to make sure that we are safe. Can we get ourselves into a position that's not going to hurt us whilst we do the wound assessment and wound management? Can we find a clean surface to use for our dressing equipment? Before we do our assessment, we should make sure our wound is cleansed of loose debris and dressing residue so that we can really see the true nature of the wound bed and make sure that we're assessing the wound and not old dressing material. So wound assessment is not easy either, along with wound healing. There is lots of things that we need to consider besides the physiology and the process of wound healing. And we're going to go through quite a lot of those. We're going to think about the holistic factors. And we're going to look at the local factors, looking at the type of tissue, infection, moisture balance, the edge, wound location and odour, and what type of closure, if it's a primary closed wound. Have we got clips or sutures that need to be removed? So we're going to go through all of those in turn, and we're going to start with our holistic factors because our patient comes first. So there are a huge number of holistic factors that impede wound healing, and we've already covered a few of them as we've been talking about the wound healing process. And here are quite a few more. Think about that past medical history. Has your patient got a condition that's going to prevent clotting or increase inflammation or put them more at risk of wound infection? Maybe they've got a connective tissue disorder that's going to disrupt that collagen production that helps with wound healing. Anything that's going to prevent good oxygenation and blood flow to the wound is going to be a factor. So things like respiratory conditions, smoking, vascular conditions, they are going to prevent all those blood cells getting to the area that we need to get there. They're anemic and low hemoglobin. What medications are your patients on? We've mentioned anticoagulants and anti-inflammatories. Is there anything else that might impact on healing? Do we need to look at those little bits of paper that come in the medication pots to check to see if they have an impact on skin or healing? Nutrition is a huge factor in wound healing. If we have poor nutrition, our skin will not be well nutritioned either. So if we've got poor nutrition, we're not going to get those cells to the area to help with wound healing. Think about your patient's lifestyle. Are they living in poor circumstances? Can they afford to get themselves to the surgery to see the practice nurse? Are they drinking or taking illicit drugs, which will impact their decision-making, their hygiene, their ability to look after themselves? We've also mentioned age. We know that the skin changes as we age. So is that going to impact on your particular wound healing? How's your patient's mobility weight? Are they able to move around? Is moving around actually going to impact on the wound itself, if it's on the foot or the leg? Are they incontinent? Is the moisture going to be a factor, or contamination? Are they sleeping? We know that most of our cell regeneration occurs while we're asleep. So if we're experiencing insomnia, not sleeping or resting well, we're not going to have good wound healing. If your patient's in pain, they're not going to want you to go and assess them and change their dressings. They may have an underlying malignancy, which is going to impact on how well their wound is going to, whether it's going to heal or not heal. So maybe think in your own time, a bit later on, think about your own patient groups. Consider what holistic factors might prevent them from healing. If you're not sure about some of these factors that are influencing healing, then pop a question in the Q&A and we'll try and explain them a little bit more later on. When we look specifically at the assessment of the wound, it's useful to remember this acronym, TIMERS. It mentions most of the factors that I've already mentioned, but we're going to go through it in turn again and make sure that we go through what we're looking for and what we need to do to manage each of these parts of our wound assessment. You might have come across some other variations as well. It was originally called the time assessment tool, but clinicians and industry have adapted it. So there's times, and the original authors have renewed the tool and called it TIMERS. They've included regeneration and repair and social factors into the acronym. So let's go through each of those bits in turn. Let's start with T for tissue type. and we're looking at the wound bed appearance. How do we describe the tissue that we can see in our wounds? Sometimes we might describe it by its correct terminology, which might be necrotic, sloughy, granulation, or epithelialization. But those words are sometimes tricky to come into our head when we're actually talking about it, aren't they? But we can describe the wound by colour. So we could say black or yellow, red, or pink, and people would know what we were talking about. When we're documenting, it's really important that we try and quantify the amount of different tissue types in a wound so that we can see with reassessments whether that's getting any less or more. Is the wound improving? Is it cleaning up, or is something deteriorating? So, for example, the wound on the upper left of this slide, we might describe that as 95% necrotic because it's got a small rim of sloughy tissue around the edge. Whereas the other wound on the top, on the right-hand side, is a mixture of different types of tissue. So we might say that's about 60% sloughy, 10% necrotic, and about 30% granulation. It can be a bit subjective, but always try and imagine your wound in halves and quarters, and that helps you to work out the rough percentage when you're documenting. To manage this type of tissue, we need to think back to the healing process. What's happening under the surface of the skin? The necrotic and sloughy tissue appears during the inflammatory phase. So we know that that needs to be removed before the angiogenesis and the granulation can occur. So macrophages and things are going to be doing some of the work from underneath, but some of this tissue can be quite stubborn and take some time to lift and remove. So we might need to think about helping it along with some means of debridement. There are different types of debridement. There's natural autolytic, so we allow the body to do it itself, but we might use dressings to maybe soften up that necrosis, rehydrate them so that that necrosis comes away a bit easier. Or we might use sharp or surgical debridement, sometimes known as mechanical, where we physically use a sharp implement to remove that tissue. Or we might use our larvae, enzymatic debridement. And the enzymes can break down this tissue and help it to lift. Our granulation and our epithelialization wounds then are in the proliferative phase of healing. So they just need protection while the body does its thing. It's already cleaned up and it's got all the right things happening. So we may just need a protective dressing over those wounds to allow them to heal. So our next bit of our time is I, which is for inflammation and infection. And we need to know whether the wound is simply inflamed in the inflammatory process or if it's infected. So we're looking for a number of signs. We've already talked about erythema, swelling and heat in the inflammatory phase of healing, and these can be present in infection as well. So go back to your wound healing process. Which part of the wound healing process is your wound in? Look at these other symptoms as well for the infection. We might see increased pain, increased exudate, and that exudate might be thicker, more pus-like. It might have changed colour from a serous-y, straw-like colour to a deep yellow or green even. You might have malodor, smell appearing. There might be cellulitis in the surrounding tissues, so they might be getting red and spreading away from the wound. Your patient might be unwell with a pyrexia or other signs of sepsis. Locally, we might see the wound breaking down, or there might be delayed or halted healing. We might see that friable granulation tissue that I mentioned in the proliferative phase of healing. And friable granulation tissue happens because the bacteria have interfered with that proliferative stage, and the granulation has become weak and easy to bleed if touched. We might also see something called pocketing, and this means a wound has small broken down areas at the base of the wound that have the appearance of holes or pockets. Sometimes they almost look like little bubbles in the bottom of a wound. Or there might be bridging, and this is where you get a fragile development of cells without underlying structure. So you can pass a swab stick all the way under, like you can see in this picture. The bridge will break down because that tissue is not viable. But how else can we tell if something's infected? Ideally, we need to do a swab. And it's really important that we do it right. If we get the right technique and we get a successful swab to the lab, we're going to get a much better result, and we're going to be able to treat our patients much more effectively. So in case you haven't been taught swabbing technique before, here's some top tips. Always cleanse your wound before you swab. Otherwise, you're leaving any surface contaminants that might be picked up on the swab stick, and that's not really going to give you a good result. What you really want is the bacteria right in the bed of the wound. Always make sure you're using the right type of swab. So it's a swab that's got a transport medium, so jelly stuff in the container. This will preserve the organisms until the specimen is examined, and it'll keep that bacteria moist. We know bacteria likes to be in a moist environment. And because of that moist environment the bacteria like as well, it's always worth moistening your swab stick so that the bacteria are more likely to be attracted to it. So moisten it with a little bit of saline. And then when you actually do your swabbing technique, it's this zigzag technique right across the wound and gently pressing into the wound as you do so, and rotate the swab, because the idea is you want to get as much bacteria on that cotton stick as you possibly can. Always worth making sure your patient has got analgesia on board before you do a swab, because it can be really uncomfortable to press a wound swab into a wound. And also, ideally, if you've got a wound that is oozing quite a lot of exudate, you might be able to collect that into a pot and send that to the lab, and that'll give them even more bacteria to work with in the lab. When you send in your form with your swab sticks, you're always going to be asking for MCNS, microbiology, culture, and sensitivity. The sensitivity is really important because we need to know if these bacteria are going to be sensitive to certain antibiotics, because the key to treating an infected wound is always going to be systemic antibiotics. But some wounds can be colonized without being infected. That means there's bacteria on the surface of the wound that's just interfering with that granulation tissue, but not enough to cause a widespread infection, just enough to interfere. And this is where antimicrobial dressings can be really helpful, and they can reduce that colonization level at local level. Our larvae therapy can be helpful at this point as well, as they break down the biofilm and remove bacteria from wounds. Our next bit of our time is moisture. So looking at our exudate or our wound drainage. And that can be really challenging to really assess the volume of exudate, because it's not always possible to collect the wound fluid. So we might need to rely on looking at the dressing that we've just removed to see how much exudate is in that dressing. And we generally describe this as high, moderate, or low. So high exudate means the dressings are saturated. We need to change them daily or even more, and there might be maceration to the surrounding skin. Moderate exudate, the dressings are wet, but they're lasting 2 to 3 days. Low exudate means your dressing is probably dry, small marking, maybe only changing once or twice a week. Remember, if your patient is losing a lot of fluid through their wound, it can affect their fluid balance, so we may need to keep an eye on their bloods as well. Management-wise, we want to be thinking about absorbent dressings if our wounds are too wet, so things like foams and hydrofibers, adequate padding. We don't want our patients turning up into clinic like that photograph with a bag wrapped around their foot, so their whole foot's going to macerate. If their wound's too dry, so we've got necrosis or slough sitting there, we might need to think about adding some hydration. So hydrogels or hydrocolloids might come in useful at this point. And then our next bit of our acronym is our E for EDGE. And in here, I've included a number of things, and some of that is that repair and regeneration as well. Our wound position is really important. We need to know, is there going to be a risk of contamination in sacral wounds or near a stoma site? Is the wound very close to something else like a drain or a stoma? That's going to affect if our dressings can be secured well. How big is our wound? We need to know that, because we need to know, is the wound getting smaller or larger, but also so that we can choose the right dressing product for our wounds. So we need to make sure we're using an appropriate measuring tool, so a disposable ruler or a probe, or some clever photography now can do grids on cameras. Always measuring your length from the head to toe direction and your width side to side. And depth, you need to go into your direct depth, but also look for any undermining or tunneling. So you might need to use a wound swab stick as in the picture and just feel around gently to see if there are any pockets or holes around the edge. When we come to documenting that, it's useful to use the clock face to document which direction you felt undermining in on your wound. And then the wound edge itself, what does it look like? Is there healthy epithelialization happening at the edge, those pale pink cells? Or are the edges quite rolled, kind of going in because the granulation hasn't filled the wound yet? The epithelium is actually trying to migrate but can't, so it rolls under. Is there any discoloration to the surrounding skin? Any purple areas? Redness for spreading cellulitis? Or any signs that there's a vascular insufficiency, especially if it's a lower limb? Is it very pale, cold, mottled, mauve looking? That's going to be quite an emergency and need some additional help. Is there dry skin that needs moisturizing or maceration that needs maybe a skin barrier to protect it? Then finally, we need to think about our social factors. That's the everything else really in our wound assessment. So is our patient in pain? Have we thought about analgesia before we even started to think about our wound assessment and our wound dressing changes? That's really important because if a patient's in pain, they're not going to want you to go near them to take down a dressing and assess their wound. So we need to manage their pain. And pain can also help us. It indicates if there's infection, if there's exposed nerve endings. It can really help with the whole process. Has our patient got an ability to receive and understand information? We know that if our patients are well informed, they're more likely to want to be involved in their wound care, and they're more likely to be concordant with the things that we advise. If we've got a choice of products to use, involve patients in that conversation so that they can be in control a little bit. Are they concordant? Is there any reasons why they don't concord? Have they had bad experiences with a particular product in the past? Are they a bit worried about coming into a healthcare setting? Are they in pain? Are they comfortable? How's their mobility? Is any bandaging or dressing that we're going to use impact on their ability to move? Are they going to be able to walk? Are they actually going to be able to leave clinic after we bandage them? Will they get their shoes back on? What's our end point objective? Is it always to heal? Is our patient nearing the end of their life? Remember that skin is an organ. As our other organs are failing as our life comes to an end, our skin is also failing. So it may be simply that we can't heal the skin breakdown because it's failing. It might be that our patient has a malignant tumour that is unlikely to heal, and we're going to need to manage the symptoms. We want to always think about patients' quality of life. Are they able to continue to work or carry out their activities of daily living? How can we disrupt their life least by looking after their wound? Thank you very much for listening, and I'm going to leave you with the Larval Therapy decision-making pathway. And this is really useful, and you'll find this on the BioMonde website, along with lots of other really useful information that helps you to make your wound management decisions. And this pathway will bring in lots of the bits we've spoken about today, looking at the phase of wound healing. Is the wound static? Is it infected? Is there any slough or necrosis? Is there a hematoma? Has our patient got any problems with clotting factors? Or is there a large blood vessel or organ exposed? Are they able to offload, or is there infection in the wound? All these things will help you to make a decision about how you manage your wound. Thank you very much. I think I've got you 10 minutes to under, so lots of time for questions.
Oh, wonderful. Thank you so much, Carole. That was an amazing presentation. I really enjoyed it, and I hope everybody did at home as well. Now, at this point, I'm going to invite my colleague, Vicky Phillips, to join us. Vicky is the Clinical Support Manager here at BioMonde, and if anybody has any questions specifically on larval therapy, Vicky can help to answer those for you as well. So, Carole, at this point, I'll just ask you to stop sharing your screen, please, if that's okay.
I will, if I can find the button. My computer's hidden it.
Oh, I think if you hover just at the top of your bottom screen, it should appear then.
My Zoom screen has minimized itself, so I can't see anything.
That's okay, not to worry. Oh, there we go. I think I've done it for you now, Carole.
Yeah. Lost you. There we go.
There we go. So hopefully everybody can see my screen again now. If somebody could let me know in the chat if you can, that would be amazing just before we move on. Wonderful. Oh, perfect. Thank you, everybody. Okay, so now it's time for your questions. So I can see lots of questions are coming through already, ladies, which is great. But if anybody does have any more questions at home, do just type those in and Carole and Vicky can answer them for you. And you can do that just by using the Q&A button. So first question, let's have a little look. So the first one for you then, Carole. Kate is asking, what's the best practice regarding cleansing a wound? Is it prior to swabbing or is it afterwards? And would you use normal saline or water to cleanse?
Oh, good question. And I think it's one that comes up quite a lot. So with regards to swabbing, I would always cleanse before swabbing. And that means that allows us to get rid of any surface debris, any dressing residue that's left behind, because when we want to do that swab, we want to get the bacteria that's right in the wound bed. So cleanse first, and then you'll get a really good quality swab.
Oh, perfect.
With regards to the fluids, whether it's saline or water, it generally depends on the type of wound and the environment that you're in. So if you're looking at something like a primary closed wound, a surgical wound or a trauma wound, and in hospital, I would certainly use saline where possible. But if you're looking after somebody with maybe a big leg ulcer, you might find it easier to cleanse that in a bucket of water. We do say potable water. That means drinking water quality. That means that it's water that's flowed through a pipe and has not been standing in a tank. In a hospital environment, sometimes our water sits in tanks, so it's not the best water to be using for wound cleansing. So potable drinking water or saline.
Oh, brilliant. Thank you, Carole. And there are actually a lot of questions around wound swabbing, so I'll just touch upon some of these for you. So Rachel is asking about the zigzag method, and she's wondering, is the Levine technique superior to the zigzag?
I think the Levine technique is the zigzag, so it's just using the name or the description.
Oh, one of the same. There we go. Brilliant. And Pauline is asking, so if you were to cleanse a wound before swabbing, would you wash the bacteria away?
No.
No.
The bacteria are far too clever for that. They're just under the surface of the wound in those top layer of cells. So that's why we suggest with your wound swab stick, you give it a bit of a press, and that squeezes the bacteria out of the surface.
Brilliant, thank you. And the final question I can see just regarding swabbing again, obviously a hot topic tonight, everybody. But somebody is asking, so is it good practice to swab a wound at the first appointment that a patient has with a clinician?
No, you only really want to swab if you've got those clinical signs of infection. Swabs, there's a monetary reason, they're very expensive to run a wound swab. So if we haven't got clinical signs or suspicion of infection, there is no reason for us to do a swab. And we do sometimes hear from doctors asking us to do routine swabs, and it really shouldn't be practice. We should only be swabbing if we're suspecting infection.
Oh, fantastic. Thank you for clarifying that, Carole. So the next question is, how does smoking, so a patient factor, how would that affect wound healing?
Question. So smoking affects the ability of your lungs to absorb oxygen, and if you've got, and that will in turn cause you to have poor oxygenated blood going around your body, and you need oxygen to help with your wound healing, bring all those cells, the right cells to the area for wound healing. So yeah, that smoking will affect your oxygenation.
Brilliant, thank you. And Kathleen is asking, so just regarding wound cleansing, are there wound cleansing guidelines in place, Carole?
Some places will have localized trust guidelines, and speak to your infection control team if you're in a hospital or a clinical environment, and they'll help you with that.
Brilliant, thank you. And she's also gone on to ask, so just specifically regarding biofilms, would you say that normal or sterile water is best when encountering a biofilm?
I think probably normal saline is probably slightly better, but the key with biofilms is they need to be a bit agitated to remove. They don't come away with gentle cleansing. So that's where you need things like your more products like Debris Soft and things like that that help to lift the biofilm off, and your larvae, which are really good at breaking it down.
Brilliant, thank you. And she's also wondering regarding certain cleansers, how long would you need to leave the cleanser in place, and when would you need to change dressings? And she's also asking about protozoans for biofilms as well.
So I think that leaving cleansers in place it refers to a specific product that's on the market, and you'd have to refer to your product guidelines for that.
Perfect, thank you very much for answering that one. So the next question I can see that's come through is regarding necrotic wound treatments. Approaches can offer differ on location and also a different clinical approach. So what's your opinion on that, Carole? She's the person at home is asking about podiatrists and nurses, and are there any differences with how these clinicians will approach necrotic wound types?
Absolutely. So particularly with podiatry, if they're looking after patients with poor vascular supply to the feet or with diabetes, they will tend not to rehydrate necrotic tissue, because as soon as we rehydrate necrotic tissue and make it wet in those particular group of patients, they become more vulnerable to infection because they haven't got the good blood supply coming to the foot to tackle that and bring white cells into the area. So particularly with diabetic patients and with arterial insufficiency, you'll see a lot of podiatrists will keep the necrosis quite dry and allow it to come away autolytically or gently, or they might do some quite radical debridement if they're qualified to do it. Debridement does need a qualification to do sharp debridement, so you might see clinicians who can't debride.
Okay, oh, wonderful. Thank you for providing so much information on that one. Now, Vicky, I've got a question for you. And Kathleen is asking, where hypergranulation is present, can larval therapy be of benefit?
Yes and no. So often hypergranulation is because the wound has been stuck in the inflammatory stage for too long, and you've had, like, your body's gone berserk. They're probably not going to do a lot once the hypergranulation has started, but you could prevent it by putting larvae on when it's stuck in that inflammatory phase, because you've probably got a biofilm or something going on there that's going to, you know, encourage the body to sort of go a little bit berserk and hypergranulate. So yeah, hopefully that makes sense.
Yeah, no, that's perfect. Thank you, Vicky. And the next question from Michelle, again for you, Carole. Michelle is asking, can you get venous leg ulcers on the feet? And would they be managed with compression in the same way that venous leg ulcers are?
Yes, you can get venous leg ulcers can occur anywhere on the lower limb, including the foot, depending where that venous insufficiency is hitting really. And yes, you would always apply compression from toe to knee anyway. So you're always putting compression on the foot, even if it's a wound on the lower limb, because you need that venous return right from the toes up to the knee.
Perfect, thank you. And we've got another question from Pauline, who you answered one of her questions earlier, and she's very grateful. But she's asking further to that, could you use a syringe to wash a wound out if it's particularly deep, something like a cavity wound maybe?
Yeah, absolutely. Yeah, you can use a syringe to irrigate. Even I've used a bag of saline, like an IV bag of saline sometimes can also be useful in a particularly large wound to irrigate through.
Oh, brilliant. Thank you. Bear with me, I'll just have a little look. We've got loads of questions coming through. Thank you so much, everyone. Okay, Carole, so the next one from Diana is, if you have a Pseudomonas infected wound, what type of debridement or dressings would you prescribe for that wound type?
I wouldn't specify specifically for the Pseudomonas. I would be looking at that tissue type. So is it necrotic or sloughy? We need to look at that tissue type to decide what type of debriding dressings we're going to be putting in place.
Great, okay, thank you. Let's have a little look. Okay. Right, apologies, we've got so many questions, it's hard to keep up with them all. Thank you, everyone. So Kathleen is asking, could you please explain the difference between inflammation terminology versus erythema and swelling?
So erythema simply means redness, and swelling would be any kind of edema or puffy tissues, really. So inflammation is the umbrella term for that swollen tissue, that red tissue, that heat. So inflammation covers the heat, redness and swelling.
Perfect.
That helps.
Thank you. Oh, brilliant. No, that's great. And another question just regarding swabbing. With chronic wound types, so wounds that are stalled in that inflammatory stage, how regularly would you swab them?
I'll go back to my previous answer. Only if we've got clinical signs of infection. Yeah. We could be stuck in the inflammatory phase without infection. So looking for those clinical signs.
Brilliant, thank you. And Elizabeth is asking, what did the M stand for in M, C and S, please? If you could just clarify.
Biology.
Lovely.
So that's sending it to the right lab.
Yeah, yes, definitely important. So let's have a little look. Kathleen is asking, in situations where vascular options are not suitable and other treatments are declined, what would you suggest?
Ooh. That's a bit vague. That's a bit difficult to answer.
Kathleen, if you want to provide some further clarification, and we'll get back to that one for you. That's not a problem at all. And I can see lots of you are asking about the slides and the webinar this evening. I think everybody's enjoyed it, Carole, which is great. And not to worry, everybody. What we're going to be doing after this evening, we will be uploading the webinar to our YouTube channel. So if you do want to watch this evening's webinar back, you can do so anytime at your leisure. It will be available on the BioMonde YouTube, so please do subscribe. Okay, so I'll just take one more question then, unless Kathleen, if you do want to provide some more clarification, we'll definitely answer that for you. Somebody is asking, if there was a foot wound which was hard to heal due to something like oedema, or a venous insufficiency or lymphedema, would it be essential to manage this to encourage healing?
Yes, so again, it's that holistic assessment. So if somebody's got a chronic lymphedema or edema, we're going to need to manage that particularly, and involve lymphedema specialists, your leg ulcer specialists in that care.
Oh, perfect. Thank you. So thank you, everybody, for your questions this evening. It's been such a joy to answer these for you, and we hope everybody's enjoyed the webinar. And thank you to Carole and Vicky for your time in answering those questions so brilliantly as well. Now, if you've enjoyed the webinar this evening, we will be back very soon with more webinars for you. So do keep an eye on our social media accounts for updates on those. We'll be providing a mixture of webinars going forward for you. So we will have some expert guest webinars again very soon, but we'll also be providing some in-house BioMonde educational webinars for you as well, specifically around larval therapy. So do keep an eye out and check our website regularly just to stay up to date with those. And as well, if you've enjoyed the session, we do offer some other forms of education for you. So we've got BioMonde Now, which is our online video library. We've got BioMonde Academy, which is our online learning platform that has bite-sized modules which you can complete at your own time, and it'll also contribute towards your CPD as well, which is great. And then we've also got BioMonde Direct. Now Vicky is your host on BioMonde Direct, and BioMonde Direct are our remote training sessions. They're one-to-one training sessions via Teams or Zoom, and they're great obviously if you want to get some training in larval therapy for either yourself or your team. So just visit our website if you want further information on any of those. And also, if you do need to contact us, you can contact us either via phone, via our clinical helpline. As I've mentioned, we've got our website as well for inquiries. And if you prefer email, then of course, we've got a clinical support email for you as well. So please do make a note of those. And we are on social media, as I've said. We're on all platforms, including TikTok, which is our newest one. And we post educational stuff on there, but we also have some funny content on there as well. So do feel free to give us a follow on those. But thank you, everybody. It's been such a pleasure to have your company this evening, and we really hope you've all enjoyed the webinar. And a huge thank you, Carole. You've been amazing and such a wonderful guest speaker. It's been brilliant. So we hope to see you all again very soon, but I'll let you enjoy the rest of your evening. And once again, everyone, thank you so much for joining us on BioMonde Live. Good evening.
Please.